Lesson day to everyone. How is everyone? I hope you are just fine, and hopefully that as we continue with our training on the 6th edition of the NTP Manual of Procedures, we will be getting more information and we'll be learning more insights and inputs on this training course. Okay, so before anything else, before I'm going to share to you the slides for this presentation. I just want to give you a brief overview for this topic. On this topic, we are actually identifying eligibility for TST and preventive treatment among LTBI, or the latent TB infection. In the 5th edition of the MOP, it was termed as IPT, or the isoniazid preventive therapy. And there's only one drug, which is isoniazid. It's being administered for 6 months duration. But in the revised edition, the name was changed to TPT. This is the TB preventive treatment. This time with 2 drugs administration with shorter duration of treatment, which is only for 3 months. So this is actually treatment for LTBI in a sense, and at the same time as a preventive treatment as well for those with high risk of developing TB disease. So at the end of these modules, you'll be able to identify persons eligible for preventive treatment. So not all persons are eligible for TB preventive treatment. So there is a need for us to really identify them. Not only learn to identify, but learn to identify who are eligible for TB preventive treatment. Also, we should also determine which patient should undergo TST to confirm LTBI prior to TB preventive treatment. So even the TST, or the tuberculosis skin test, there are also only qualified persons can undergo this test prior to preventive treatment. So not everyone, not everyone will undergo TST. So we will also be able to determine who are those patients should undergo TST. Perform the necessary screening to rule out active TB prior to TB preventive treatment. We know very well that it's very important that before the administration of TB preventive treatment, we should first rule out active TB, because when we introduce these drugs under TPT, which is only equivalent of 2 drugs, so we are actually giving a way for the development of MDR-TB. So it's very important to really rule out first active TB before initiation of any TB preventive treatment. We need to also learn how to prescribe the appropriate regimen for both adults and children. So there is a regimen for adults and regimen also for children. Then we also need to monitor patients during treatment. Just like when we have the TB treatment, we also do monitoring of treatment. And then at the end of each treatment, there should also be the treatment outcome. So we can also assign treatment outcome. Okay. So there are definition of terms. First, contact investigation. So this is a systematic process of identifying. So we will be identifying first people with previously undiagnosed TB among the contacts of an index person with TB. Then the source, excuse me, the source person with TB if the index person with TB is a child. Okay. And then candidates for preventive treatment. Now let's go to household contact. person who shared the same enclosed living space as an index person with TB. So this refers to the household members, no? Or a family that is living in one house. So these are household contacts. No? They are living together in the same enclosed living space with the index person with TB. Now, for close contact, a person who is not in the household. So that means to say, he or she is not a member of the household, but was able to share an enclosed space with the index person with TB during the 3 months before commencement of the current treatment episode. Moving on, index case refers to the patient, no, the TB patient. This is initially identified people with TB of any age in specific household or other comparable setting. So when you say source case, these are a person with infectious TB, usually bacteriologically positive pulmonary TB, who transmits infection to one or more other individuals. Then latent TB infection, or the LTBI, a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens with no evidence of clinical manifestation of active TB disease. So from the word latent, so that means to say, any person who got infected in the past, but is not manifesting any symptoms of an TB disease is considered as LTBI. In reality, there are a lot of LTBI than the active TB disease. If you see the statistics, around 2 billion people are already infected with TB. That is globally. But of the 2 billions of people who are infected, only a portion of that, around 8 million, will develop the TB disease.
It's 12 o'clock.
So that means to say that the LTBI, most of them, what? They are in the dormant states, and they became actually a reservoir for future active TB disease. Okay, so let's now go to TB preventive treatment, or TPT. Treatment offered to individuals who are at risk of developing active TB disease to reduce that risk. Okay, also referred to us as LTBI treatment or TB preventive therapy. So in order to stop the progression from infection to disease, so there is a need of TPT, or the TB preventive treatment, especially those with high risk of developing active TB disease. So we can initiate or administer TPT. So why is preventive treatment necessary or important? Okay. It is important because, as already mentioned, LTBI, the latent TB infections, are the reservoir of active TB disease. So if we could not control them and if we could not manage them properly, then there will be no decline in global TB incidence rates when you reach the 2035 targets, because we want to have the desired decline in global TB incidence rates comes 2035. Looking at this graph, if we will just go on with our current strategy, no, the current global trend is at 1.5%, decrease of 1.5% per year. So we will never reach our target when we reach the year 2035. But then, If you're going to optimize the use of a current and new tool, and this new tool will be integrated comes 2025, including treatment of latent infection, then there will be a gradual decrease of TB incidence, especially when we reach the year 2035. So this shows that there's really a need of preventive treatment. And a lot of regions, not only in our regions, we are really short of this. As far as accomplishment is concerned, we are not really hitting our targets, in identifying LTBI and in initiating this treatment regimen or the TPT. Okay. So there's a risks and benefits of LTBI actually. Okay. So what are they? The benefits of LTBI, and when we do the TPT, is that it will prevent the progression to active TB. As already mentioned, that if an LTBI will not be managed properly, sooner or later they will progress to active TB, and this will add even more to our TB incidence. The risk, okay, so we will have to balance it. There's the benefits and there's the risk. Adverse drug reaction to LTBI treatment, or develop the drug resistant, especially for those undetected active TB. This will be the risk. So another benefits, and this is increase in individuals with high risk of progression to active TB, okay? And individual with positive tests for LTBI. For the risk, increased risk if individuals with medical conditions that predispose to drug reactions, and if active TB is not ruled out. So here we can see we have the risk and we have also the benefits. So TB contacts, PLHIB, TB risk groups should be evaluated for eligibility to receive TB preventive treatment. Okay, so all of these, the TB contacts, we need to investigate, we need to assess them, the PLHIB, even the TB risk groups. Okay, so this is the #1 policy in our TB preventive treatment. So #2 policy is tuberculosis skin test, or TST, or the interferon gamma release assay, or the IGRA, shall not be required prior to initiation of TPT, preventive treatment, in the following eligible individuals. As already mentioned in my previous slides, that not everyone requires to undergo TST. Okay, so this policy #2 showed us that there are exemptions to the rule. That means to say that there are people who are already eligible for TPT even without TST. Oh, it is not required. The word there is not be, shall not be required prior to initiation of TPT. And who are these patients? People living with HIV. Okay. Children less than 5 years old. So below 5 years old, household contacts of BCTB, or bacteriologically confirmed TB. Individual age, 5 years and older with who is a household contacts of BCTB with other TB risk factors. Later, we're going to explain to you who are the TB risk, what are TB risk factors, what are they, and how can we identify them, okay? Now, TST shall be performed in other individuals prior to TPT. So these are the ones that really need to undergo TST before initiation of TPT. So they are children less than 5 years old, but this time the child is a household contact of clinically diagnosed TB. So they should undergo TST first before initiation of TPT. Individual age 5 years and older and household contacts of BCTB, no? The age of the child is 5 years old and older. Household contacts of BCTB with no other TB risk factors should also undergo TST. Close contacts of BCTB, okay, should undergo TST first, and other risk groups. Now, this slide is just a presentation of the risk of active TB. No? This is the full estimate risk for active TB among household contacts by age and baseline LTBI status compared with the general population. So we have the age of the child, the age. Then we also have, this is under LTBI positive at baseline. No, they were already identified as LTBI. And in this column, regardless of baseline LTBI status. So we can see that we always mention that below 5 years old, no, they are really have a high risk of developing TB disease. No? If not properly managed, if you fail to give the TPT, okay? And we know that when the child started to grow from 5 to 14 years old, the risk is much smaller as compared to the risk under or below 5 years old. And it just, the risk of developing active disease will just rise, no? When the child reaches the adulthood, okay? So let's continue. In the policies, active TB shall be excluded by symptoms or chest X-ray screening prior to initiation of TPT. So we have to exclude, no, any symptoms, no, or chest X-ray screening prior to initiation of TPT. And TPT shall not be given to contacts of RR and DRTB, no. It cannot be given to contacts of RR and DRTB. So all healthcare providers shall ensure completion of the treatment. So let's move on. Let's go to the procedures. A, identification of individuals eligible for TB preventive treatment. So how we're going to identify the individuals eligible for TB treatment? Number one, identify individuals who require further evaluation to assess eligibility for TPT. So as for PLHIB, all PLHIB age 1 year old and above. Okay, so you have to evaluate them, assess them for eligibility for TPT. Household contacts, all household contacts, all ages of BCTB. And then the less than 5 years old, household contacts of CDTB. clinically diagnosed. Close contacts, all close contacts of BCTB case. Now, these are the other risk groups I'm telling you a while ago. These are patients on dialysis, patients preparing for organ or hematologic transplant, patients initiating anti-TNF treatment, and patients with silicosis. Moving on. For contacts, check if the index case is RR, okay? Rifampicin resistant or MDR TB. TB preventive treatment should not be given to contacts of R or MDR TB. They need to be followed up with symptom screening, okay? Chest x-ray screening or expert test every 6 months for at least 2 years. Assess presence of TB signs and symptoms. If present, evaluate appropriately following procedures in screening and diagnosis. So always exclude active TB in your assessment, because active TB can never undergo the so-called PPT. So how do we exclude active TB? As for TB signs and symptoms, if positive signs and symptoms should be evaluated further for active TB. So if there is signs and symptoms, so there's a need to evaluate further for active TB. Maybe the patient doesn't need TPT, he needs treatment, complete treatment for TB. If there is no signs and symptoms, perform chest x-ray, okay? If positive findings suggestive TB, again, we evaluate further for active TB. If the child is less than 5 years old, contact, exception to chest x-ray screening prior to TPT. So what if chest x-ray not accessible? Okay, so again, physician may decide to give TPT but avoid rifampicin containing regimen. So this is just a slide, an algorithm showing to us the TPT algorithm in adults and children with HIV equals to more than or equals to 5 years old. So following this algorithm, it's easy to do our next course of action. So if you have adult children living with HIV aged 5 years old and older, you screen people with any of the following symptoms. So our cardinal signs and symptoms for TB will be at least we have 2 weeks or more current cough, fever, weight loss, night sweats. So if there is no signs and symptoms, so that means to say we can now do chest x-ray, okay? So any abnormality in the lung, field, or other findings suggested to TB, if none, then we can proceed giving TPT. If yes, then we have to investigate for TB and other diseases. If not TB, then we can proceed giving TPT. If TB, then we treat the usual TB regimen, okay? So right here we have to answer, we have to screen people with any of the following symptoms, not all of these symptoms are actually needed, no? Any of the following. So if yes, then we have to investigate for TB and other diseases. And after investigation, it's not TB, then we can proceed to TPT. Next algorithm, excluding active TB prior to initiation of TB preventive treatment. This time, TB algorithm in children with HIV age 1 to 4 years old. So again, children living with HIV 1 to 4 years, Screen people with any of the following, again, the cardinal signs and symptoms, or history of contacts with a person with TB. If there is none, no cardinal signs and symptoms, so we can proceed giving TPT. If yes, then we have to investigate TB and other diseases. And if our result is not TB, then we can give preventive treatment unless contraindicated. So if it is TB, then we have to treat for TB. Now let's go now to TPT algorithm in HIV negative child contacts less than 5 years old. Okay. The algorithm is too small. I could hardly read it. But anyway, let's just proceed. Okay. So children less than 5 years of age or below 5 years old with a household or close contact of pulmonary TB. So we check for symptoms again. Okay. For children, like fever, not eating well, anorexia, weight loss, failure to try to gain weight, fatigue, reduced playfulness, and decreased activity. No? These are actually the signs and symptoms for TB in children. Okay. If the child is well and the child is below 5 years old, okay, so, and the child is a house contact of a BCTB, then give preventive treatment. Okay. Now, if the child is symptomatic but not lasting more than 2 weeks, we have to follow up and check for persistence of symptoms. Once it is resolved, the child is well, and the child is a household contact of a BCTB, then give IPT. But then if the child is not a household contact of BCTB, but a household contact of clinically diagnosed TB, so we need to perform TST first. Once the TST becomes positive, then we proceed in giving the preventive treatment. Once it is negative, we give information about TB, advise him or her to seek care if symptoms develop. Okay? So going back here, follow up and check for persistence of symptoms. If it doesn't resolve, so it meets the criteria for presumptive TB. So that means to say, follow the diagnostic algorithm, reevaluate for preventive treatment once preventive treatment once active TB is excluded. Now this time, we will be having this TPT algorithm in HIV negative at-risk individuals more than or equal to 5 years old. Okay? So you follow up the screening algorithm for active TB. So no TB symptoms, X-ray not done. So you do the TST. So positive or not required, you do the chest X-ray. Now, if the chest X-ray has no abnormality, then you can treat for LTBI. But if the chest X-ray has abnormality in the lung field or other findings suggestive TB, investigate for TB and other diseases. Once the active TB is excluded, then you can proceed with your treatment for LTBI. Okay, if the child X-ray is normal and there is no symptoms, you do again TST. Once it is negative or TST is not available, give information about TB, advise him and her to seek care if symptoms develop. Okay, and you just have to follow the algorithm, and you will not be lost. Okay, just follow it. Then, if the TST is positive or not required, you can treat for LTBI. Okay, so let's continue with the policy. Number 4, the following eligible groups do not require TST, as already mentioned. Let's memorize it by heart. These are the person living with HIV, less than 5 years old, household contacts of BCTB, equal or more than 5 years old, household contact of BCTB with other TB risk factors. So these are the groups which do not require TST. So do not always say, just like in the previous implementation of TB in children, sir, we do not have TST. How can we diagnose TB in children? No? We are always relying on TST. But then, even at that time, there was already a policy that even without TST, we can still give IPT. So just like the same is true with our current MOP. Okay. Let's continue. Other risk factor for 5 years old, household contacts of BCTB. So these are the PLHIB, diabetics, smokers, those with immunosuppressive medical condition, malnourished, with multiple people with TB in the same household. So we don't need to do TST for this group, okay? Even though the age is more than 5 years old, but they are household contacts of BCTB with other risk factors, as already mentioned, so no need to do TST. They are already eligible for TPT because of the multiple risks. Perform TST in the following individuals. Again, so you're going to perform TST in the following individuals: less than 5 years old, household contact of CDTB. 5 years old, older, household contacts, BCTB, but with no risk factors for TB. Okay. All ages, close contacts of BCTB. Other risk factors: dialysis patients preparing for an organ or hematological transplantation, anti-TNF treatment, and silicosis. If TSA is not available, it's not recommended to offer TB preventive treatment to these individuals. So bear this in mind. If you don't have TST, you cannot recommend or offer TB preventive treatment to these individuals. So that means to say, there is a dire need of TST before initiation of TPT for this group. So in a table form, they came up with this checking eligibility of different risk group for TB preventive treatment using TST. No? So you just have to go over with this. As we can see, this was already explained to you, but this time it was just put in a table as a summary and for a ready reference. No? Who are those who doesn't require TST? Who are those who requires for TST? And who are those not eligible for TPT? So this is just a summary table for all the discussions we have in the previous slides. Let's continue. If TST positive or if eligible even without TST, exclude active TB prior to giving TPT. So if TST is positive or if eligible even without TST, okay, you just have to exclude active TB prior to giving TPT. Explain the rationale for TPT and need for further evaluation. Evaluate the presence of other risk factors and pregnancy. So in the initiation of treatment, inform the patient that he or she is eligible for TPT. Provide key messages for the person and his or her families as necessary. Again, we have to provide key messages, no? Not only to in the treatment of active TB, but even in the treatment of LTBI. We have to give the rationale for TB preventive treatment, the duration of treatment, the reasons and schedule of regular clinical and laboratory follow-up for treatment monitoring, and the potential adverse events. Okay? So tracing mechanism in case of treatment interruption. So there should be a tracing mechanism. So this is just the same when we treat an active TB case. Availability of free of charges services. We can also discuss with him or her their social and financial needs or offer possible sources of social support to enable adherence to treatment, just like the DSWD, SSS-CSIS, others, and from the LGU. Determine the baseline weights, okay? This is important, especially when we monitor response to treatment. Assign the appropriate TPT regimen. Okay, the currently available regimen under the program is 6 months of isoniazid. This is the currently available. We are still using isoniazid. But once available under the program, there is the so-called weekly dosing with isoniazid and rifapentine for 3 months. This is 3 HP, okay? Except for pregnant women, pregnant and less than 2 years old. There's also alternative 3HR for children, no? 3 months of isoniazid and rifampicin for children, and another alternative 4 months of rifampicin for adults. Okay? So again, currently, we are still using the isoniazid for 6 months. But once it is already available under the program, we will be shifting to this regimen, which contain isoniazid and rifampicin, or either of the way, isoniazid rifampicin or rifampicin alone. Okay? So these are the instruction on proper dosage based on weight. We just have to follow the weight of the child, and then you follow the recommended dosage. You don't have to compute it. It's already on this table, and follow the recommended milligram, okay, or in millimeters. So dosing for 6 months isoniazid, 3 months isoniazid rifampicin, and 4 months rifampicin in adults. So you just have to follow this. For isoniazid, 5 milligram per kilogram. The range is between 4 to 6 milligram per kilogram, not to exceed 300 milligram daily. For rifampicin, 10 milligram per kilogram. Ranges 8 to 12 milligram per kilogram, not to exceed 600 milligram daily. So this is the dosing for the 3 months weekly rifapentine, and isoniazid in adults and children. Okay. So since it is already here, I don't need to explain further. You just see it on your manual of procedures for details on this. Perform baseline liver function test in the following. Okay, liver function test is very important. Individuals with risk factors of hepatotoxicity. Okay, so we have to get the history of liver disease, if any. And we also need to determine the regular use of alcohol. If the patient is using regular use using alcohol, alcoholic, chronic liver disease, HIV infection, whose age is more than 60 years old, pregnancy, or within 3 months of delivery. So do not give TPT if liver function tests cannot be done at baseline and monthly during treatment, especially for those with high risk factors for hepatotoxicity. Okay, so you really have to have that baseline and monthly during treatment. Exception: PLHIB without other risk factors for hepatotoxicity can still be given TPT, even if liver function tests cannot be done, because the benefits of treatment still outweighing the harms. Okay, so they are PLHIB, and we know that the co-infection with TB is very high, in terms of mortality. So that's why we have to have the so-called balances between the benefits and the risks. Now, for this, if our PLHIB can still be given TPT, even if LFTs cannot be done. Perform baseline liver function tests in the following individuals. Okay, so for adolescent and adults more than 15 years old, keep 3 HP regimen if available. Okay, 3 HP, isoniazid and rifapentine. It can be given even if LFT monitoring cannot be done. Okay. Perform baseline liver function tests. If 3 HR or 6 isoniazid for 6 months, isoniazid will be used. Okay. If only 3 HR or 6 H or isoniazid are available, but LFTs cannot be done, TPT may be given based on clinical judgment and informed decision of clients. Okay, another group, determine other comorbidities such as diabetes, HIV, malnutrition, and not other medication. We have to manage or refer accordingly. Okay, then you adjust the regimen if needed. Prescribe 10 to 25 milligrams per day of pyridoxine, vitamin B6, if given isoniazid at risk for peripheral neuropathy. Okay, so such as malnutrition, chronic alcohol dependence, HIV infection, renal failure, diabetes, are pregnant or breastfeeding, infant taking isoniazid, or whose breastfeeding mother is taking isoniazid 5 to 10 milligrams per day. Discuss the appropriate treatment adherence and support mechanism with clients. Consider the most suitable location of drug intake and treatment supporter based on client's condition. Okay. Accomplish the form, the TB card, the form NTP-ID card, register the patient in LTBI register and ITs. As if the patient requires any further social or financial support. Refer accordingly to other programs providing social protection. So treatment consideration in special population, pregnant women, isoniazid and rifampicin can be used, including breastfeeding. Rifapentine should be avoided. Okay, so this is very clear. For pregnant women with HIV who are already on ART, we can defer the TPT until 3 months postpartum. Okay, just defer the TPT, especially those with HIV who are already on antiretroviral therapy for HIV. Breastfeeding, isoniazid or rifampicin can be safely given. Oral contraceptives. Okay, so rifampicin and rifampicin, the risk of decreased protective efficacy against pregnancy of oral contraceptives. So just a reminder, especially for those women taking oral contraceptives, once they are in the TPT, So there will be a risk of decreased protective efficacy. They might get pregnant because rifampicin and rifapentine, no, possess what? An effect in the oral contraceptives. It reduces its efficacy. Okay? Liver disease or history of liver disease. Treatment isoniazid, rifampicin, rifapentine should not be initiated in individuals whose baseline liver transaminases is more than 3 times elevated or not done. Okay, for those who have liver disease or history of liver disease with baseline SGPT is 3 times higher or not done. So we cannot also initiate the so-called TPT. TPT should not be given to individuals with end-stage liver disease. Acute hepatitis or viral hepatitis or acute viral hepatitis, defer TPT until the acute hepatitis has been resolved. You just have to defer. Renal failure, isoniazid, rifampicin, rifapentine, biliary expression can be given in normal dosages to patients with renal failure. Normal dosages only. Now, patients with severe renal failure should receive isoniazid with pyridoxine to prevent peripheral neuropathy. People living with HIV, rifampicin and rifapentine can be co-administered with efavirenz. Okay, rifampicin or rifapentine cannot be co-administered with protease inhibitors or nevirapine. Baby born to mother with active TB disease, note, TPT not necessary if mother has taken more than 2 months of treatment. Okay. So if the mother has taken more than 2 months of treatment, so TPT is no longer necessary. So what are we going to do when a baby born to mother with active TB disease? Refer to specialist, pediatrician if baby is not well. If the baby is not well, so upon birth, then you have to refer it to specialist or pediatrician. If well, you do not give BCG first. Instead, give TB preventive treatment with pyridoxine at 5 to 10 milligrams per day. At the end of the treatment, perform TST. If TST is negative or not available, give BCG. If the mother is taking anti-TB drug, she can safely continue to breastfeed. I think this statement here is very much similar to our previous MOP. Okay. Monitoring of treatment, ask patient to follow up 2 weeks after initiation of treatment and then at least monthly thereafter. Clinical assessment during follow-up visits. So you have to clinically assess them during follow-up visits. And of course, we have to get the monthly weight. Check for presence of signs and symptoms of TB. Okay, if diagnosed with active TB, then you have to stop with TPT and start treatment for active TB disease. This is well understood. Check for adverse reaction. Manage any adverse drug reaction and refer it if needed. If there's a need to discontinue anti-TB drugs due to major ADRs, do not reintroduce. Okay. In case of flu-like syndrome due to rifapentine, consider a switch to daily rifampicin-containing regimens, or if not possible, isoniazid alone. Drugs can be started at a full dose, but at 1 drug per day. Okay. Advise patient to contact their healthcare provider if they become aware of symptoms. Perform liver function tests monthly for individuals with normal baseline test result. Okay, only for those with abnormal baseline test results. Adolescent and adults receiving 6 months of isoniazid and 3 months of isoniazid and rifampicin. Discontinue treatment if liver transaminases, as already mentioned, elevated 3 times. okay, plus symptoms, and elevated 5 times regardless of symptoms. Continue manage of comorbid condition and refer it necessary. Explain the importance of adherence and completion at each encounter. Record the visit, drug intake, and all findings in Form NTP-TB card. Assigning LTBI outcome. So at the end of each treatment, we're going to assign the outcome. Completed, that means to say, completed the prescribed duration of treatment, remains well or asymptomatic. Lost to follow-up, interrupted TB preventive treatment for 2 consecutive months or more. Okay, dies for any reason during treatment. Failed, develop active TB disease anytime while on TPT. So once our patient develop active TB disease, is considered as failed in the outcome for LTBI. Not evaluated, transferred to other health facility, but whose treatment outcome is not known. Include here discontinued by physician because patient cannot tolerate this. Example like the adverse drug reaction. Okay, so far this is the full content of my lecture on the TPT or the TB preventive treatment. So after this lecture, of course, you have some exercises which will be discussed to you, which I'm going to discuss to you this coming Friday. So once again, thank you and have a nice day.